Good morning, everybody.
Good morning.
Thanks for joining the session this morning. My name's Michelle. I'm previously a consultant midwife at Bucks Healthcare. I'm joined today by Julia Phillips, who's here on the screen, and Brogden, and I'll tell you a little bit more about their roles as we go through the presentation. We're going to talk to you about a project that we implemented that used simulation to improve outcomes for pregnant women. So in 2018, this report was published. It was published by the Joint Colleges and talks about failings in the ability to provide appropriate care to women that develop quite significant complications during pregnancy and childbirth. Many women experience problems in childbirth, but actually what we're talking about is the kind of problems that led to an ITU admission for certain women. So how big is the problem? Well, according to the UK Intensive Care National Audit and Research Centre, they document that for every 1,000 maternities, 2.4 of those end up in critical care. We know, though, that this is just the tip of the iceberg. Many women aren't admitted to a critical care unit. Instead, they're provided care on labour ward by midwives that aren't appropriately trained to deliver that care. It's challenging to provide that care in an environment like the labour ward, and so that usually these women end up with a substandard level of care, unfortunately. Apparently, according to a survey that was undertaken in 2014, only 6% of units actually appropriately train their midwifery staff to provide appropriately enhanced care to women that develop complications during or shortly around the time of pregnancy. A recent report on the UK mortality related to pregnancy documented that multidisciplinary training and teamwork were really important fundamental elements of being able to provide safe care on labour ward. And they advocated protected time for education to deliver midwifery skills to critical care teams and critical care skills to midwifery teams. And it's important because actually what we know is that although the documentation says that there are 2.4 per 1,000 admissions, we know that the reality is probably 3 times that. So there's a huge number of cases that are managed locally, probably not very well, and that has a huge impact on the way that a woman recovers following childbirth. Also, those admissions to ITU have a significant impact on critical care, and especially at the moment when they're undergoing huge pressures because of COVID. So we're left with this kind of dilemma around this group of women and making sure that they get appropriate care. And the reason it's so important is because women need to be able to provide or to feel like they're providing care for their baby when it's born. And what happens when a woman is taken to ITU is that she leaves the baby goes home with the dad, starts to bond with that family, and the woman is left in critical care, not having any contact with her baby. Further impacting the problem, this report was published just this year, and it talks about the first 1,001 days of a baby's life. And that takes a baby right from conception through to the age of 2. It's a really critical time for the cognitive, emotional and physical development of the baby. And we know already that pregnancy and childbirth changes lives of families, exponentially. And the physical health and well-being of the mother is a really important means of enabling that early bonding happens and that the baby develops appropriately. So separating them is a huge deal. Rarely these women need ITU, rarely do they need the full support of an ITU department, but because there isn't the appropriate skills on labour ward, they end up being admitted there for sometimes days, sometimes weeks while they receive that care. So we decided to develop something that sits in the middle, something that we called enhanced maternal care, something that would reduce unnecessary admissions to ITU, but provide proper high dependency level care in the maternity unit for these women. So we were stuck in the kind of too busy phase really for developing this project. It had been in our minds for quite some time, and there never seemed to be a good time to get started. It was always felt like it was going to be a huge deal, and so we kind of pondered on it for a lot of time. We talked about it a lot, but in February this year, for some reason, we all decided to come together. And the team comprised myself, then a consultant midwife, Bridget, who is our simulation lead at the Trust, Julia Phillips, who will be talking to you in a short while. Julia is a nurse consultant and the lead for critical care outreach, so it was really important that we had Julia's input right from the start. We also had Will Burtz, who's consultant anaesthetist, Marie Zammit-Mannion, who was the labour ward lead obstetric consultant, and last but by no means least, Phil Duggleby. And Phil is an ITU consultant, but he also wears a hat in maternity, so he was in a really unique position to be able to give us insight from both sides of the situation that we were in. And Phil was really the driving force behind this project. He was the one that first started talking about it, but it always felt like it was probably something we'd get to eventually. But in February, we managed to get everybody together in a room. I don't know what made them come, but they did, and I'm really grateful for that. And I think possibly it was because we were all a bit tired of everything COVID related, and this felt like something really positive that we could do. And also, I guess, Julia, with her critical care hat on, was hoping that we could reduce the admissions to the ITU department at a time when they really needed the bed space. So on the 24th of February, we all got together on Teams, and Phil plucked a date out of the air of the 1st of September, which wasn't actually that long away, but we all agreed for some reason. So we decided that 1st of September this year was going to be the launch for our enhanced maternal care service. So we had 6 months to develop a pathway, which didn't exist. We had to write all the associated guidance and SOPs that sat alongside that. We had to equip the rooms, so we had really basic rooms on our labour ward, didn't have decent quality monitoring, we didn't have the documentation to support that monitoring, and more importantly, we had to design, write and then deliver a whole training programme. And the training programme was delivered for the midwives in order to give them some critical care skills, but also there was a really important part around training the critical care outreach team in some midwifery skills. So we managed to achieve that. 1st of September, we opened our doors to the enhanced maternal care service, and within 2 weeks, we had our first 2 patients through the doors. And I remember getting a WhatsApp at about 11 o'clock at night from the consultant on labour ward saying, we've just admitted our first EMC patient. And it felt a bit wrong to celebrate it, but actually what we knew was we were keeping this mum and baby together, but we were providing safe care in a labour ward environment. And that felt really great. The midwives were really empowered by the new skills that they had learned. The woman was happy because we kept her and her baby together. Baby didn't have to go home to her husband or go to the neonatal unit, which is what normally would happen. And ITU kept her bed free, which was really important. So I'm going to hand over to Bridget now, because the real key part of the success of that was the quality of the education that we were able to deliver through simulation.
Thank you, Michelle. So from my perspective, this is how the start of the SIM project felt. As Michelle's already said, there was lots of enthusiasm and energy. We were post-COVID surge, just starting to calm down. It was lovely to be thinking about something else other than COVID. But there was lots of ideas floating around, and you sort of wondered which ones would grow and thrive and which ones would just fizzle away and pop. So when we set about developing the training programme for this new service, I think one of the strengths of this was that the simulation team were involved from the very start. Simulation wasn't an add-on after they'd made the decisions. It wasn't a nice to do if we've got the time. We were involved in those early communications and in all of the steps of their planning, so that when they were thinking about what equipment they needed for the beds, what skills those midwives needed to develop, we were thinking, okay, have we got that equipment in the sim suite? Can we borrow it? How would it be best to teach those skills to the midwifery teams? And a good example of that was, as Michelle has described, the documentation. The clinicians developed a daily assessment chart for women in the EMC service, and we piloted that on the first run of the programme, and they made changes, got feedback from the midwives before it was implemented into practice and used on real patients. So that was really great to be involved from an early stage. And what we did realise was this was going to be a big course, We decided on a blended learning approach, which included lectures and discussion, skills-based simulation stations, and high-fidelity simulation as well. And the added complexity was having another room running where we had the sessions for the critical care outreach nurses as well, being led by an obstetrician or a midwife. So we took over lots of rooms. We obviously had to still think about the complexities of social distancing and the COVID restrictions, but we managed to do that. And I think that when you look at, we're very fortunate at Bucks. We've got a high fidelity simulation suite, and we have a Lucina, the birthing simulator, who's an amazing piece of equipment. But when midwives or any staff come into the department, sometimes they feel anxiety and stress, and we know that simulation can cause that in people, and the psychological safety of anyone coming into the department is really important to us all. And what we do to reduce that stress and to maintain their safety, there are a few steps that you can take, such as planning really well your scenarios. So when we wrote these scenarios, we've really spent time looking at the detail, because if you get the details right in that scenario document, then the scenario will flow nicely, and the delegates, it will make sense. It will be a plausible story for them, and they will then know what to do. They'll know what actions are required of them, and the sim will go very smoothly. Often I find that if staff in the simulation are looking puzzled, it's because we've maybe forgotten something, or a piece of information that isn't there that they need. And so it's really important to do that planning well beforehand. We would normally have a dry run for a course this big, but because we'd worked with this team of educators and clinicians over a couple of years, we didn't feel in this instance that was necessary, but I would always advise that for new programmes. And the preparation on the day, it's always about checking and double checking. It's always about checking and double checking that equipment's going to work, opening the dialogue in the control room before the simulation starts. So getting the technical team and the clinicians talking and comfortable. We define our roles. We have a very short pre-brief before each scenario where we talk about what we hope will happen within the scenario and what we're going to do if it doesn't go to plan. We use, as you can see from the slide there, we use an embedded person in the simulation. Or a plant, that title's often used. And we find if they're in direct communication, if they're wearing a headset and the control room are talking to them regularly, then that makes so much difference in terms of how the simulation flows. We also introduced a couple of years ago now a simulation pause card, which is a laminated card which says stop, and if at any time during the sim the participants feel uncertain, feel anxious, they can hold up this card and we just pause the simulator, have a chat, think about, give them more information if they need that, and try to get the simulation back on course, or we could stop at that point if we needed to. So these are just some of the things to maintain that psychological safety throughout. And as you can see, that's our control room there on that bottom picture. And when we're in the control room, we try and keep numbers to a minimum, and obviously COVID restrictions meant that was even more important. And we have what we call cockpit rules within our control room, so that for those 15-20 minutes that the simulation's running, everybody's focused on what's happening in the room. We try not to have other conversations, avoid distractions, and really just communicate about the simulation itself. One more thing to say is, I think with Lucina, she's an amazing piece of equipment, but she is sometimes a little bit too clever, and my advice is that she can outwit even the most experienced technician, if I don't know if any of you have used her yet. if you're running, for instance, if you're running a PPH scenario, which we did on the day, be careful not to let her bleed too long, because before you know it, you're in a cardiac arrest situation that you may not have wanted to be part of your scenario. And also, when you're using her, just be mindful of the time it takes to reset the scenario and the number of people, because she's a good size, heavily pregnant lady. So plenty of time to clear up and people to help with those moves. When we move into the debriefing, we use a modified diamond tool, and what we would do is have a very quick chat in the control room with the key debriefers. All of our faculty have debriefing training, and it's very much a case of them just taking 1 or 2 learning points into the debrief and allowing the participants to do the talking and do the reflection. And we're happy to share our tool if anyone would like us to do that. So what did we achieve from this project? Well, I think at the HE in 2020 really finally outlined in their strategic document the values and the real range of opportunities that simulation learning can give. It's not just a training tool anymore. And I think that with this project particularly, we achieved quite a few of these goals. As Michelle's mentioned, we're looking to improve patient safety and the quality of care of these women. And we were training our staff, developing them, and by doing so, hopefully, potentially having an effect on their own well-being if they feel more confident to deal with situations that they're facing. And we're hoping to overall improve the patient experience, which is the key part after all. We also were able to test a system here, a new pathway, before it was actually launched on patients. Okay, so I'll just pass you over to Julia. Thank you.
Good morning, everyone. Hope you can hear me. My name is Julia Phillips. As you've heard, I'm Nurse Consultant for Critical Care and Outreach at Buckinghamshire Healthcare Trust. So I lead something called the Critical Care Outreach Team, who are a team of intensive care nurses and practitioners. And one of our main aims is to try and avert ICU admission by detecting deterioration and also going to the bedside of acutely ill patients. So due to our intensive care experience, we have an extended skill set around critical care, and we bring that skill set to the bedside to the benefit of patients. And also very grateful to Michelle and Bridget and others regarding this partnership to provide better care for mums and babies. So it was very much a partnership between critical care, my team, anaesthetics and maternity. And as you've heard, that very much ran through the educational programme. So even before we got to simulation, we ran theory days, of which we were all guest speakers. And that was an opportunity to start building relationships across these teams. We then brought it into this practical day, initially of skills stations, where we would teach skills like ECG monitoring, chest auscultation, airway management, for example, and then bringing both teams in, so the senior midwives and the critical care outreach practitioners, into the simulation. So it was a real sort of blend of shared learning. What I would say is there's recognition, obviously, that midwives aren't general trained. So unlike registered nurse training, they don't have a general training. It's very specialist within midwifery, and they have a very autonomous role. But conversely, from a critical care outreach point of view, we also have very little obstetric training. And again, the beauty of that shared learning meant that as critical care outreach practitioners, we could have the expertise and certainly the learning from our colleagues within midwifery, and that was something that we would go out, have lectures, while conversely the midwives would have lectures around sort of critical care experience. The other things that we've done to try and embed that learning, because often you see that sort of theory practice gap when you're going to the bedside, is actually develop some shadow opportunities. So we've had some midwives that have come into our intensive care unit to shadow the work of an intensive care colleague, and also to come out with the critical care outreach team, because we have skills in history taking, clinical examination, for example. So again, some really good sort of blended learning there. We also have some practice development nurses and practice development midwives, so they have an educational remit. And again, as part of this programme, a workbook was written which was competency based. So it doesn't stop in the classroom. There's certainly a sense of embedding that learning at the bedside in real time. So we've had 2 patients that have now come through the enhanced maternal care, both of which have done remarkably well. And I think that relationship building has been absolutely key, where outreach can come, support at the bedside, the care of these patients, but also use that as an educational tool. So when we're caring for arterial lines, for example, which conventionally would be in an intensive care unit, we can support with that care at the bedside. Equally, these patients that need enhanced monitoring or specialist drugs to treat their condition, it's really about embedding that learning in practice. Also, within the standard operation procedure that's been written to support this pathway, we say to our midwifery colleagues, please do escalate to us. So bleep us so we know as soon as that lady is admitted into that designated bed. And also call our intensive care colleagues, because we want to support the care of these ladies to try and avert ICU admission. And as you've heard from Michelle, that keeps mum and baby together, much better pathway, and hopefully in the longer term with better outcomes. So very much happy to take questions at the end, but essentially that's our partnership working. And I'll hand you back to Bridget for the last slide.
Thank you very much, Julia. Thank you everyone for your attention. We open the floor to questions.
And was this something that you designed yourselves? Did you put this together yourself? I know it's obviously the adaptive guidance, but was it yourselves that adapted this?
Yes, we use Diamond. This comes from the debriefing work of Diamond, and we just added in, we put it in this format that we felt was very easy to use within the debriefing room, and changed the wording a little, gave a couple of examples of what we were looking for. Yeah, so thank you.
Hi. So initially we trained Band 7 labour ward coordinators, and we have just started, we're just recruiting, interviewing on Monday actually for a lead for the service. So their job will be then to disseminate that learning to the 6s that predominantly work on labour ward. We've got quite a highly rotational workforce, so we have midwives that work frequently across all areas of the service. So what that person will do when they come in is develop a core team that will be predominantly based in the EMC space, and then they will develop those competencies and also all of the stuff that needs to sit around this service, the audit, the safety monitoring, and the development of the actual physical space itself as well. EMC, enhanced maternal care, yeah. Yes. Yeah, and if there are no women that are requiring that level of care, then they just contribute to labour ward. Okay. That's a really good question. Having just gone through the approval event for our local universities, who are now... Oh, okay. Oh, okay. So approving the new curriculum for the midwifery standards, which has a massively high focus on kind of continuity of care at the moment, doesn't it? And there isn't, and that's the issue, isn't it? There isn't a huge amount of undergraduate education around high dependency care and high risk pregnancies. Certainly when I trained, we had none of that. We were expected to be able to, at the point of qualification, deliver normal care, whatever that is. And now this is why we now have the need for these courses, because as Julia said, midwives are direct entry. They don't develop those kind of nursing skills that are really important to this care. So hopefully it will come. You know, it's competing, isn't it, against everything else that universities are trying to teach midwifery students at the moment, but certainly something for the future, hopefully.
We have very good links with our local universities.
Yeah, we do.
We've got
We do.
so I think we'll be making that case to them. Won't
Yeah,
we, over
hopefully.
the next couple of years.
Bye.
This might be a little more information but my background is in intensive care, and I was just wondering whether there was any connection between them starting to introduce this in maybe the paediatric intensive care course within the universities, so that by the time you became a sister of intensive care, you then have some kind of midwifery input instead of approaching it later on.
Did you hear that, Julia? About
Not very well. I heard. Would someone be able to repeat the question?
So embedding, so similar to embedding the skills for midwives in undergraduate education, about implementing some elements of obstetric knowledge, midwifery knowledge in critical care training.
Absolutely, would wholly support that, because obviously there is a criteria of ladies, unfortunately, that do have to come into intensive care, even with an enhanced maternal care unit. You know, your HDU and ladies that may actually require ventilation will still have to go through that pathway. And also, arguably, with a critical care outreach service like we have, most acute trusts have that. It's about prevention, so it's about early detection, it's about trying to avert ICU admission where able, or facilitating a timely admission. So I think absolutely, and what we've done in our second wave of education, appreciate this isn't at this stage undergraduate, but actually targeting our staff in situ. So now the ICU nurses are actually coming through this educational programme, so they get additional training and support in obstetric emergencies. But absolutely, we should be starting with undergraduates, and that should be embedded into the curriculum.
Thank you. Any other questions? No? Well, thank you. Thanks all for your time this morning.